Good day and welcome. I'm Dr. Jennifer Taylor, Director of the Center for Firefighter Injury Research and Safety Trends at the Dornsife School of Public Health at Drexel University. The first center is comprised of data and policy scientists, epidemiologists, and organizational psychologists. We are the research responders for first responders. If you're working, we're working. We have your backs when it comes to using objective data for decision-making. Thank you for joining us today. When we think back to September 11th, 2001, we remember the incredible attention paid to the fire service for about a decade thereafter. There was incredible support and acknowledgement of the heroism and sacrifice made by these first responders. However, the EMS part of the fire service did not benefit from this attention. Past history was that people signed up to put wet stuff on the red stuff, not be Florence Nightingale. Now, 60 to 90% of the work that a fire department does is EMS. Prior to the coronavirus pandemic, it was not unusual for many fire departments to run out of ALS ambulances on a normal day. The pandemic is shining a light on a system under incredible stress and at a breaking point. Talk about flattening a curve. This is the one that concerns me. The line in blue shows us a problem in the United States. Since 1980, the blue line shows that the number of calls for EMS have gone up 320%, without an increase in EMTs, paramedics, cross-trained firefighters, ambulances, or any support for the incredible mental health burden this call volume takes. Here at the First Center, we are measuring the stress and mental health impact firefighters and EMS responders are experiencing doing EMS. So to me, it feels like the coronavirus pandemic of 2020 is EMS's 9/11. And that presents an opportunity to revisit what fire-based EMS needs to serve communities well, while at the same time protecting the mental and physical health of those who respond. When we've looked at media and organizational messages about the coronavirus's pandemic and the impact on the fire service, we noticed a gap. There was not much discussion about what EMS needs in terms of resources, staffing, policy, and standards. So today we are going to put our heads together to address that problem. And since I miss baseball so much, if you'll permit me the analogy, our leadoff hitters are fire departments who will discuss EMS needs before, during, and after the coronavirus pandemic. On deck and in the hole, experts will then discuss fire-based EMS needs in terms of equipment, apparatus, and staffing. Our cleanup hitters will talk about their ideas for EMS standards development, what exists, and what needs to be further developed. Each participant will talk for 5 minutes, and after that, and after they are all done, we will have 15 minutes, open forum for your questions, ideas, and lively discussion. So while we would all like to be on the West Coast enjoying the sun, let us begin with San Diego, California, and EMS Battalion Chief Dan Froelich.
Thank you, Dr. Taylor. I'd just like to start out with an overview of the system in San Diego. San Diego Fire Rescue, we are the first responders with paramedics on all of our resources responding to EMS calls, and our partner is AMR, who does the ambulance transports. So looking at the system overview, pre-COVID-19, our system averaged about 140,000 calls a year with about 110,000 transports. Since March 13th, we've seen about a 15% decrease in fire department responses in our city, with AMR decreasing about 17% in responses and 25% in transport. COVID-related notes in our EPCRs from the paramedics out on the line, about 1,583 as of this morning. And those are folks checking a box that there's either confirmed COVID or possibly COVID-related EMS response. We've got several cruise ships that have taken up port in San Diego or are anchored right off our shore. That's kind of new for us. Those ships are rotating in and out routinely throughout the week, and we're seeing several transports off those cruise ships that are COVID related. We're closely monitoring the border with San Diego and Mexico, and the border traffic has decreased, but our call volume still remains the same for EMS needs at the border. Overall, the strain on our response system has been minimal, but the time on task is increased as we start responding to these COVID emergencies and having to do stuff differently with PPE and decontamination. Okay, moving over to managing the COVID-19 response. On the morning of March 13th, we pulled some key people into a room to discuss managing COVID-19. By that afternoon, we had activated our incident management team, and we've been at it ever since. Some of the keys to our success is strong labor management relationships on our incident management team. Since this is an emergency, an EMS emergency, I'm the operations section chief. AMR and a lifeguard representative hold deputy operations section chief positions on our IMT. And we've taken in key leadership members from each one of the labor groups, from fire, lifeguards, and AMR, and they're an active part of our incident management team. Pre-COVID, we had additionally occasionally run out of ambulances. I'm happy to report that AMR recognized the potential of this emergency and upstaffed additional ambulances. We have not run low on ambulances during this emergency. So the status of our workforce. Pre-COVID, we were facing the same issues most of the other EMS systems across the nation are facing. Heavy call volume, not a lot of breaks, people asking, what are we doing to fix the system? Currently, staffing is good, our people want to come to work, but they're scared. They're asking questions like, will we be exposed? Will I expose my family? When will this end? And I'm sure a lot of you across the nation are getting those same type of questions. So future needs, again, this is my perspective and kind of how our mental health is going. EMS, I believe we need to improve the communications between the agencies that come together in these type of emergencies. Often the focus is on hospital systems and not necessarily EMS response and what's going on out in the streets. Secondly is resources. We need to have resources that are specific to the EMS response. For example, CDC published some great guidance on EMS back on March 10th, 2020, and that was the last time it was updated. So that kind of forced a lot of us to move to hospital guidance, healthcare system guidance, and that doesn't always meet the needs of what's going on out in the field. As far as mental health goes, happy to report this is day 2 of our mental health stand down, basically taking a look at behavioral wellness. We're bringing clinicians, chaplains together to check on our people, see how they're doing, see if there's any needs out there, and we'll start addressing the needs moving forward. That's a snapshot of what's happened at San Diego Fire Rescue.
Sorry, Rob, I realized I didn't unmute myself.
It happens. It's the joys of the world in these sorts of meetings. Thank you, Jen. Thank you, Dan. Just switching over to Dallas. You know, before a pandemic hit the nation, you know, our system, our department is a large one. Large urban makes well over 200,000, 230,000 calls a year. About at least 85% of that is EMS related. So we're looking at roughly around 200,000 EMS calls a year. You know, we ran a study a couple of years back to measure our unit hours of utilization, the UHU numbers for our units. And when we looked at rescues, we're well over the optimum range. Optimum range is generally considered to be about 45 to 55% of your unit in use, and our average at that time was at over 60%, peaking at over 75%. Call volume increases 3 to 5% every year. We simply do not add resources at that same rate. Up until very recently, it had been nearly 10 years since we'd added a rescue unit to our fleet. You know, estimates recently have ranged anywhere from 14 to 17 additional full-time ambulances we need, and that's just to catch up to where we are on our current call volume. You know, rescues or ambulances cost in excess of $1 million a piece, so those present a sizable budgetary obstacle. You know, we manage our resources similar to most large urban departments. We don't run out very often. We have mechanisms in place to avoid that. We have a status called overload. We're in that daily. What overload means is that units are called back into service more quickly, whether it be for training or education or after transport. Certain things are suspended. Transport destination decisions are altered based on that status. And like I said, that's a daily occurrence. Yeah, you know, our hospitals can go on divert when they get overloaded. Fire departments can't do that. We have to make the calls. We have to respond to the need. You know, as demonstrated by our UHU numbers, our personnel are overworked. Our resources are stretched too thin. We can call people back into service and we can meet the call demand most of the time, but things like food, bathroom breaks, and sleep are secondary for our personnel. Never mind decompression or de-stress time. Our personnel are hanging in there right now. I just described where we were before a pandemic hit us. You know, we took an oath, and I still firmly believe that most of our people would say that they're happy and fulfilled if you asked them how they feel about their job in general. But we have burnout, we have disengagement, we have morale issues, we have a lot of frustration. These problems manifest themselves in areas like disciplinary problems, job performance issues, substance abuse, depression, divorce. You know, currently we're adding a pandemic into the mix. You know, there is no normal. You don't get to go home and have your normal life. On the job, you have to gown up to the point of almost being at a hazmat response on regular, everyday medical calls. The strain on our personnel is palpable. So what do we need? As Dan talked about, this is my perspective, and this is what we need in Dallas. You know, other than 16 more rescues, the fire service is part of a system that is broken in many, many ways. You know, we don't operate mobile intensive care units. Not really, not on most of our calls. We operate a social service outreach program. We operate a transportation service that takes people with non-emergent conditions to an emergency room that operates as a clinic. So often we are highly trained, licensed medical providers that operate a taxi service. And that's frustrating. That drives our personnel insane. They took an oath and they're highly trained. You know, when you discuss the fire service, one of our greatest strengths is our greatest weakness at the same time. You know, we improvise and we overcome. We do more with less. And so where do we go in the future? You know, that has to stop. We have conditioned our communities to expect more and more from us while our budgets are reduced and our resources are spread further and further. Something has to give. Either expectations and our role and responsibilities need to change, or our budget and pool of resources need to be greatly expanded. So that's where we are in Dallas. Thank you.
Thanks, Rob. Appreciate that. And so this next section of panelists are going to talk about advocacy for fire-based EMS needs, focusing on equipment, apparatus, and staffing. And it's our pleasure to welcome Robert McClintock, Deputy Director of Fire and EMS Operations for the International Association of Firefighters. Thank you, Rob.
Good afternoon, everyone. First, I would like to start off by thanking Dr. Taylor, her team, and the Drexel University for this opportunity to participate on this webinar today, as well as for their continued effort and work they put toward making the fire service a safer work environment for us all. I would like to thank General President Shapeberger, General Secretary Treasurer Kelly, and the entire IAFF for their continued support and unwavering leadership during this pandemic. More importantly, I would like to thank all the first responders and healthcare professionals on the front line for all of your hard work and dedication in dealing with this pandemic. Finally, I would like to offer my thoughts and prayers to those who have perished from this dreaded disease. Although we're still in the midst of fighting this, I think it's extremely important to continue to document and capture all the necessary steps that were taken to overcome the obstacles we faced during this pandemic. We're really in some unprecedented times and uncharted waters, having to develop policy and guidance on the fly, such as placing our workforce in quarantine or isolation, performing self-screening both on and off duty, including temperature checks twice a day, and establishing return to work policies specific to COVID-19. After action reports will spell out all these lessons we've learned, capturing the new SOPs and new SOGs that were created to handle this pandemic. For instance, steps taken to ensure workforce resiliency, altering dispatch treatment and operational protocols, along with PPE acquisition and reuse, and the list can just go on and on. All these things will need to be taken into account for future planning. We can't wait and need to start focusing on our legislative efforts now. Our voices need to be heard. The IAFF and our local affiliates must continue to advocate for the workforce as they continue to fight this pandemic. The economy was thrown into a recession, and we're already hearing the rumbling from the mayors and city council members around the country calling for cuts, layoffs, and furloughs. This is not new to the fire service, as history often repeats itself, and in times of recessions, like in 2008, fire and EMS services were the first ones on the chopping block. Today, we're seen as the heroes and hailed as heroes, but we know from 9/11 that fades away rapidly. We need to push our Senate, Congress, and local leaders to ensure that the funding for the grants, for the AFG grants and the SAFER grants are put into place. And not only are they put into place, but funded even more heavily than they are today. Over the years, we've seen these funds get reduced time and time again since 9/11. Unfortunately, over the years, the fundings that were reduced, and we need to keep pushing now that to increase that funding and maintain a level that will continue to support operations, especially through times like these. We need to advocate for other COVID-19 stimulus funds or any funding that will assist municipalities with overcoming their budget shortfalls without hurting or placing the burden on the workforce and jeopardizing public safety. There may be an opportunity to push for presumptive legislation for COVID-19, similar to the presumptive cancer legislation that recently passed in many states. There might be an opportunity for hazard pay or workman's comp benefits or other benefits for the workforce. We need to capitalize on many of these as possible. Moving on to a different topic, unfortunately, we have seen complete failure at all levels of government when it came to preparation and stockpiles of PPE. It's very shameful that there were so many expired items in these caches. It will be imperative to press for funding to replenish the national stockpiles with PPE and other equipment used to protect our workforce and treat patients effectively. Personally, I think we should recommend the creation of separate stockpiles, one dedicated just for first responders, one for healthcare providers and healthcare systems, and one for other essential workforce personnel. We shouldn't have to compete against each other for limited resources. Currently, fire and EMS agencies remain at the bottom of the priority list of PPE distribution, thus leaving many of our members unprotected. We can't rely solely on local, state, or federal government. We may look to need to create regional and even agency stockpiles in the future. We shouldn't be forced to create guidance to reuse PPE, especially masks that were designed for single use. This just shouldn't be happening. On another topic, this pandemic has proven the need for EMS to evolve in its ability to provide services other than bringing patients to the emergency department. We've known for years there's a better way to do this, but only recently received some support at the federal level. Centers for Medicare and Medicaid Innovation Team, in conjunction with CMS, has stood up a pilot project, Emergency Triage Treatment and Transport, ET3, which had the capability of expanding to Medicaid and private insurance carriers to reimburse for the following: treat in place, treat and release, telehealth, telemedicine, and transport to alternative destinations. This transport to alternative destination piece is currently approved by CMS for reimbursement during this pandemic. Unfortunately, the project has been put on hold until at least the fall of 2020. But this shouldn't stop us from pushing states to issue waivers or better yet permanently change the regulations by creating protocol to treat and leave in place, perform telemedicine, and transport to alternative destinations such as urgent cares, mental health facilities, substance abuse clinics, and the stand-up ERs that we're seeing today. During this pandemic, most states have issued emergency waivers for the following. They've implemented specific COVID-19 dispatch protocol, treat and leave in place guidelines for both ALS and BLS, altered response configurations to minimize the number of responders being exposed, altered treatment modalities to minimize invasive procedures that would expose first responder to a high risk of contracting COVID-19. They've come out with different ways of deconning equipment, apparatus, and stations. We must implore that annual fit testing be completed on all required masks that may be needed or used during these pandemics. There may be a need for pandemic training and an increase in pandemic response guidelines. So in closing, there's a lot of work ahead of us. As the workforce continues to fight on the front lines, the IAFF, other organizations, and affiliate leaders need to forge ahead, ensuring the workforce remains intact and is properly equipped to do the job and provide optimum service to the public. Finally, but more importantly, we need to remember to take care of the workforce by providing peer support and access to mental health services, not only because of the stresses of having to go to work to fight this pandemic, but the fear of potentially bringing it home to a loved one. So let's lead and not lag. Thank you, Dr. Taylor, and I look forward to answering questions later.
Thank you, Rob. Really appreciate your insights there. Continuing on in this section, I bring to you the data queen of the fire service, Dr. Lori Moore-Merrell, President and CEO of the International Public Safety Data Standards Institute, and she will be sharing her slides. She is also a paramedic. To you, Lori.
Thank you, Jen. I am going to, if I may, share my screen. I do have some slides to bring with you, with me today. So let me just get those up. So Jen, can you just confirm that everyone is seeing the slides?
Yes, ma'am.
Okay, great. So good afternoon, everyone. Thank you so much for sharing some time with us this afternoon to get some insights, obviously, into Jen's topic of where do we go from here? And I think that's a fantastic question. And it shows vision in that we need to be thinking now. Often we are all living in the moment. And as Rob just alluded to, there's a lot going on that cause us to have to do that, whether it's PPE, whether it is the overall exposures, those contracting the disease, the quarantine issues, all of those things that Rob spoke about cause us to have to live in the moment. But some of us must rise up and say, where do we go from here? We have to have vision and plan ahead. Part of the scope of what we are doing to influence this and what I want to share with you today, of course, is using the data that are available to us today to help us understand where we need to go. So in sharing a couple of slides with you, let me just go into presenter mode here, Jen, and see if that's coming up. There we go. Okay, so we are going to use, for today's example, our INFORS, the National Fire Operations Reporting System data set. And with that are what we call our COVID-19 dashboards. And so immediately when we were declared the stay-at-home orders, the pandemic had hit the US, early in March, we began to ask a lot of our users to go ahead and establish a first-class data element in their CADs. In other words, you were already having your dispatchers ask questions. Have you been on travel? Do you have shortness of breath? All of those questions that were helping them to understand who may have the symptomology or a probable patient of COVID-19. So with that, we were able to establish some of these first-class data elements that could be brought then into dashboards for insight. So I'm going to share with you some data from Columbus, Ohio today, and their dashboard that is all real-time information. So we're able then to filter by various aspects of that first-class data element that tell us then not only about their response, but as you're going to see in a moment, about the responders, which is very important for us planning to go forward. So we can see even in this dashboard on the right, how many of these types of calls they have had in the time frame since about March. This is about a 2-week time frame. So it's from March 15th to March 30th is the time frame that I have in these particular slides. But you can see the dashboard allows them, if you look at the lower left, they can actually track by day what we're seeing in that curve. We've all heard about flattening the curve, right? So they're actually able to watch for their community, where in the first responder arena, they are able to see that kind of insight. We're also able to help them track in real time what calls are being made, who's making those calls, which units are responding, what battalion they're occurring in, what shift is making the most of them. So you can begin to see how many a day, which units are making them, as I said, just in the dashboards themselves. And these are updated every few seconds. So whatever is happening real time. We can also point out, again, which unit, right? So you're looking here at just a snapshot I could click and filter by medic 14, and you can see that that particular medic unit has had 69 calls in that 2-week period. That's a lot for any one individual unit in this type of call alone. That's in addition to everything else they're making. One of the other insights we're able to do is to give them down to the employee. So these are employee ID numbers, and I want you to look at the exposures, and you can see the top two there. They have, you know, orders of magnitude higher exposure probability here and higher probability for contracting the disease because of those additional exposures compared to their counterparts. And so having that insight to look ahead and have our decision makers say, hold on, maybe I need to rotate personnel on apparatus. Maybe I don't need to keep exposing the same 2 medics, you know, to these calls, because you'll be able to highlight the addresses, for example. So here are frequent flyers, as we call them, or high utilizers, right? So I can down to the address. You can see in that address at 217 North Grant, they've had 17 calls there in 2 weeks. So if you're from Columbus, then you'll know that that's a homeless shelter, right? But what unit keeps making that call, right? Is this the same medic with the same 2, you know, on each shift that are making those calls? We may need to rotate personnel. So these are the insights that we need. We're also gathering the demographics on the communities that are being impacted the most. We can show the hotspots, and this is something that you want to be able to do in your own community. Where are you targeting and seeing the hotspots within the communities of these types of calls? Because that's going to have insights, not only for PPE distribution, but also for, again, exposure tracking for your personnel. And then again, we can track that trend by hour, by day, so that you are watching the system. And when we're seeing that flattening of the curve, this may help you to decide about rotating personnel, your quarantines, which stations you could use for that isolation, all kinds of different insights that you can glean from your data. And the other thing that I want to talk about is individual exposure tracking. So Jen, if I may, I'm just going to show a video. Just watch. This is our exposure tracker. So for those on the call, if you have not downloaded this from the App Store, you need to today. Set up your profile. It's absolutely free for any medic, any firefighter, any law enforcement officer. Download it and begin to track your exposures. We immediately added COVID-19 in the EMS module. So you'll be able to track these exposures. We don't know yet what the long-term ramification of this disease will be. And so it is imperative, and there's no presumption. You see in the news that we have like the 2 Chicago firefighters who died from COVID. They are going to be covered for line of duty death, but that is not the PSOB benefits, right? That's local Chicago fire line of duty death. Now that will help, but who's making those decisions? Also in the app, you're tracking your PPE. So we can watch your PPE use, and these data can all be used by the CDC, and we're working directly with them to make sure that they know what first responder PPE is being used and where we have shortages. So it's vital, and I encourage you to pass this along. Download the app, set up your own individual career diary, track COVID-19, track the other exposures that you have on the job, whether it is for carcinogens, your EMS bloodborne pathogens, hazmat, all of those things in your app, and keep that career diary with you. So Jen, with that, I will just encourage everyone to think through that first class data element in your departments, track it, watch your responders closely. We're going to need that information going forward, who's been responding, and then of course, track your exposures, because all of these things will contribute to us knowing what we're going to need to do going forward, and having that vision for looking at our crews when we've got a lot of people sick. How do we continue when we have no more money for overtime? All of those kinds of things as we look at an economic crisis that is looming due to the pandemic. So I'll stop there, Jen. Thank you.
Thank you. Thank you, Lori, very much. Appreciate that. Finally in this section, we welcome Dr. Bill Jenaway, President of the Congressional Fire Services Institute Board of Directors, mayor of many small towns, retired fire chief. He does it all. So Bill, take it away, please.
Thank you, Jen. And first of all, thank you to all of my co-presenters today. This is excellent information, and I'm learning as we're going through this as well. For my session, I would like us to consider 3 points. The first one is that since Benjamin Franklin founded the Union Fire Company in Philadelphia, we have been pigeonholed as firefighters. In my 50 years that I've been engaged in this discipline, we've taken on a new role every decade. We need to rebrand who we are to get the full recognition of who we are, what we do, and most importantly, what we need to do our job. We are infrastructure. We are social programming. We are professionals that everyone calls when they need help. We're not firefighters. We are all hazards responders. And whether we're talking to members of Congress or state legislators or our local town officials, we need to convey that we respond to all emergencies and emergency medical response, accounting for 65 to 75% of all of our call volume. Many people just simply don't understand this. Many people who make decisions about what money we get and how that money is distributed don't understand that. We really need to be on an educational campaign with elected officials at all levels. Secondly, we need to take a look at the grant programs and assess whether we need to change what are high priority and low priority items. I believe the lack of readily available PPE for first responders validates that we need to create a super high priority list of equipment. Basic tools like PPE, including masks and radios, the gear that every first responder in career and volunteer stations need to perform their mission safely when responding to a fire or other call. Once we achieve this end, we can then fund high priority and lower priority items. If we don't do this, who's going to protect the country when the first responders are not available to respond? And lastly, there needs to be a discussion in Washington, D.C. Could be a congressional hearing or a stakeholders conference or other type of forum. It doesn't matter, but we need to address this reduction of federal focus on the fire service. While the fire service is to a great extent a local responsibility, there are areas where the federal government has a role, just as it has a role with law enforcement and education at the local level. Over the last decade, the value of our first responders has waned in a couple of areas, and it raises some questions and concerns. One, is our federal voice being heard when USFA, an agency at the federal level that represents over 1 million first responders, is buried in DHS and FEMA hierarchy? Secondly, the military, and this is one that I am passionate about. The military has been an excellent proving ground for developing new first responder technologies, including thermal imagers and robotics and other technologies. Yet for the last decade, it has been silent. We need that to change. Also, whether wildfires, hurricanes, tornadoes, earthquakes, pandemics, or other catastrophes that first responders deal with, we seem to be on a roller coaster of support, only receiving interest during or right after a disaster, when we are needed most, and typically working with some constraints, such as being without needed resources. If we are to adequately respond to significant events, we must have the tools to do the job before the job starts. Having metrics to support our requests is critical, and we need to stop using approaches and concepts from the 90s and use metrics and real-world needs to support the front lines of this country. Now, I'm not suggesting to change formulas for distributing funding to career or combination of volunteer departments. I'm simply suggesting that every fire and EMS department in the country have the basic equipment that they need to do their job before we award grants that have low priority needs. Let's stop and think about it. We wouldn't send our military into a war or a firefight without the right tools. Why are we sending first responders and EMS personnel into this war without the necessary safety tools? Thank you, Jen, and I hope that we get a few questions at the end of the session.
Thanks, Dr. Jenaway. Appreciate it very much. Now we're going to go into that final section of the webinar where we talk about the idea of standards for EMS and what development we need there. I'd first like to welcome John Montes, Emergency Services Specialist for the National Fire Protection Association. Thank you, John.
Thank you, Jen, and thank you to the Dornsife School of Public Health for hosting this important webinar, and also to my co-presenters. I'm honored to present with all of you. So when you talk about standards in EMS, I think it's important to understand that there's two worlds about standards in EMS. One is that EMS thinks they have a lot of standards, but what they really have is regulations, policies, and protocols at a state or local level. Nationally, anything that's put out for EMS as it relates to standards from the federal government is, for the most part, not required. And the reason for that is because EMS is a state-run issue. There is a federal agency that is responsible for EMS on the national level, and it's under the Department of Transportation under the National Highway Transportation Safety Agency. So EMS is really kind of buried within the federal government when you think about that, and it creates problems. But there are standards out there, and specifically when we look at things like COVID, there are safety standards that are very, very applicable to EMS. And they are absolutely 100% applicable to the fire service, and to the non-fire-based EMS, they're applicable, but they have to accept them. And I'll get to why that's a problem. So when you look at NFPA, the entire 1500 series, NFPA 1500, 1521, 1561, 1581, 82, 83, and 84 are all incredibly important at this time. NFPA has recently put out a lot of information about 1581 specifically because it's the standard for an infection control program for fire departments. And the reason that those are applicable to EMS is because any fire department that runs EMS, those standards apply to them. And it says it right in their purpose and scope. A question we get often is our NFPA standards mandatory? The answer is they're only mandatory if it has a legislative or policy adoption in your community by an authority having jurisdiction. Otherwise, they're considered an industry best practice. So those standards are universally used throughout the United States and around the world, and they're very applicable in this sense. The problem is that they all say fire department, and they're in a red book. And while the fire service does the vast majority of 911 EMS, or some part of 911 EMS, the fire service is really only probably about 30 to 40% of the entirety of EMS in the United States. The others include private EMS, volunteer, third service, nonprofit, lots of other models. And so that creates conflict because while the fire service has moved down the road for decades and decades now of creating safety standards and developing safety policies and protocols, private EMS and non-fire-based EMS is playing a little bit of catch up. And that's because EMS is just frankly newer than the fire service. When the fire service was writing standards in the 1940s and 50s, EMS was a thought. It was a thing that came out of the military, like Bill was just talking about. So that's created some issues, but I can tell you that those 1500 series standards are very applicable to private EMS. They will work for private EMS or third service EMS, non-fire-based EMS. But because EMS has that, I wouldn't call it a fracture, but has that difference, that's why those standards don't spread across borders. So we have to do something about that. And the NFPA has been working very diligently to do that. And the way we've done that is we've been including representation from outside of the fire service on standards that are applicable to EMS. The best example is NFPA 3000. As a matter of fact, Lori Moore is a committee member for that standard. We made sure that while the fire service had full representation, non-fire EMS had full representation in the development of that standard. And by doing that, we hope and we believe that it will be more acceptable to EMS outside of the fire service. Because the reason EMS struggles to make standards is because EMS can't get along and find consensus to make standards. And it's a matter of getting everyone to the table and talking about it, and then we're incredibly successful at doing it. So it's happening, it's a new thing, it's a challenge, but it's gonna do better for both fire and non-fire based EMS in the future to have better, more efficient safety standards and to be inclusive of both. as we move them forward. But a question we often get is, well, EMS doesn't have health and safety standards. They absolutely do, especially fire-based. It's a matter of finding them. So that is one thing that has come up quite a bit with COVID. And so what else are we doing to improve it? One of the big issues in the fire service prior to COVID was contamination. And so the NFPA formed a new technical committee that's drafting a contamination control standard. We made sure that not just fire service folks are involved in that, but we also included law enforcement and EMS because they go to those same incidents. So these things are going to be applicable to them as well. And the more we do this and the more we include EMS, and hopefully in the future we include EMS in other standards like 1500 and 1581, the better off we are to get more safety standards out there for EMS. And that will help improve working conditions across EMS in the future. And one last thing, when I talk about the fact that it's difficult to get EMS all on the same page, there's another factor to that, and that is that in the fire service, when you talk about who speaks for the fire service nationally, there's really 4 or 5 big dogs, right? There's the union, there's the fire chiefs, the Volunteer Fire Council, the NFA, CFSI. But those groups, if you can get them all to the table, they find consensus for the most part. EMS, there's about 14 different organizations that all say they speak for EMS. And so that creates conflict in and of itself. It's a lot more difficult to get all 14 of those groups down to a table and say, what are we going to do to change things? But we're doing our best to do it. So I appreciate this today. I'd love to continue this discussion. And thank you so much. I'm going to hand it back off to Jen.
Thanks, John. Very much appreciated. And the last panelist in this section about standards development is Casey Grant, the Executive Director of DSRAE Consulting and the former Executive Director of the Fire Protection Research Foundation. Casey, over to you.
Thank you, Jen, and thank you for hosting this activity. This is an important topic, and I'm glad that I'm part of it. I'm going to be quick, realizing I'm the caboose and wrapping up here, and I'll actually include one of the questions that was in the chat box already that I'd like to respond to. But when it comes to research and how that fits in to this picture, we're here for the long term. If the answers are easy and you can come up with the answers in a standards forum, for instance, then do so through the consensus process. But if it's a longer term issue requiring deeper dives, that's where research comes in. We're here for the long term. And clearly, as we address issues going forward, we can see that research impacts standardization, standardization impacts public policy, and it also impacts the culture internally within organizations and externally with communities and so forth. So it serves that very important baseline over the long haul. Now, I do want to point out, we focus on research for the emergency response community and the healthcare community and others as applied research. We're looking for clear, definitive answers that will help us move forward. And I want to point out that even as there was a question in the chat box about levels of compensation, one of the key pieces that we're always trying to address in research, and it was what Laurie had talked about, is data. Data is critical. It's our radar screen to understand and see what's going on, to influence public policy and other issues such as compensation and the resources, the limited resources that we have available to address the safety infrastructure. So as we go forward, just realize that research itself, it takes time, it takes resources, it takes a lot of planning. We often tell folks, look, if all you need is a simple home video to get the answers you need, then do that. But if you need an epic Hollywood production, well, let's do that as well. And those kind of things do take planning. I will end with just sharing, the simple example with this COVID pandemic. It was only a few years ago as we experienced SARS and then Ebola, and the questions came up about, well, how do we clean our gear, and how clean is clean? And that's a current deeper project that we're doing a really hard dive on to be clear and have the metrics so that we know if and when we clean whatever we've been exposed to, it truly is clean or clean enough. But that's the kind of issue that research addresses. I just want to end by thanking everyone out there today, all emergency responders across the board, all receivers, the entire healthcare system. This is an epic and unprecedented time for us all, and we're truly grateful for the services provided.
Thank you, Casey. What I'd like to do now is ask all of the panelists to reboot their videos so we can all participate in fielding some of these questions. And so I'd like to begin with some of the comments. Casey started addressing them in the Q&A. Okay, fantastic. So we had one in particular, a person raised the point that there's no question that the fire service, both in the past and even now, and in the time of stressed budgets and many states and municipalities cutting budgets and shredding budgets, what strategy should be used now to garnish the newly needed support measures for first responders like the fire service? And I just want to add to that another comment that says, is there a plan to share parts of things like N4's dashboards to address the metrics issue that Bill brought up with policymakers to inform the pleas for funding? So if my panelists could just raise their hand who wants to tackle that. Sometimes I'll ask you as individuals, but Bill, Jenaway, you want to start?
Sure. As a sitting elected official who is dealing with this right now, I think the one thing that the fire service has to do is to remind those in elected positions and those in the general public that right now, it doesn't matter how many parks and swimming pools and community centers and so on that you have, and it doesn't matter how many libraries there are, no one's going to them. And if we don't solve the problems that we have in the field with responding to the COVID cases and dealing with those COVID cases, then we're not going to be able to reopen those other assets. So we become the primary asset, not the secondary or tertiary asset. And I think that people forget sometimes that we are one of 10 or 12 different departments in a community's budgeting and operational process. But I can tell you, looking hard at it, what's being used the most in my community right now are public safety assets. And if we were to look at cutting those first, we would be in drastic problem on a routine daily basis. And then after that comes the sewer department, and after that comes public works. So some of the major drains on budgeting, which are those other things that go on in a community, they really need to be put on the back burner when we look at making sure we're solving the public safety issues. Because that's why elected officials are in business. That's why they do their job, is to keep the public safe from everything else.
Lori, do you want to weigh in on this as well?
I would love to, and I think Bill is spot on with what he just said. All of those things have to be addressed, and certainly as usual, and Casey alluded to it as well, you're going to need the data to address them. So we're going to have to know about coverage capability. We're going to have to know about effective response forces. We're going to have to know about how much your, the deployment cost, right? We're going to have to know municipal finance enough to understand, is there money, is there not money, where they're prioritizing. Just like Bill said, they're going to have to prioritize, and we are going to have to advocate that the priorities are public safety, and then all of the others that he brought up. So N4's dashboards, we have about 80 departments that are onboarded, and yes, that data is being compiled. It is being shared directly with the CDC. And so we're working with them for those data flows right now. The first 4 departments, major cities of impact and hotspots, have already gone over, and we are updating that and starting to do that data flow. So we are feeding them real-time data as much as possible. The same is happening with the exposure tracker. It is, by the way, completely free. So get your people on the exposure tracker, and they have the option whether or not to share their COVID-19 data. Please encourage them to do so, because that is where we're going to be able to build our case for our PPE and for our benefits going forward, and for, frankly, crew size and all of those other things, to have enough resources in the field if we have people who are sick. And now we all have to look to the fall at a resurgence or possible resurgence. So let's keep that in mind.
So Lori, that brings up a good point from one of our questions from the chat. And so maybe Rob and Dan, Rob Borse and Dan Froelich, you could address that. The question is, are you seeing the supply chain for PPE for EMS opening up, or is it still a scarce commodity? Because as we go into second and third waves of the pandemic, this is, this person is concerned that the amount of PPE is going to get even more scarce.
I take that. I know it's a struggle every day for us. We have a huge logistics team that's out there trying to find supplies, working with AMR's network of supplying, our own outside, everybody's all hands on deck in the logistics world trying to find stuff. And we have enough to just get by for weeks in front of us. We're not looking, and we don't have a lot of stuff piled up to get us months and years down the road. And that's a big concern. Later today, I'm having a meeting with EMS staff just looking for what's happening for wave 2, wave 3. How do we stockpile stuff? How do we get supplies that are actually accurate, that aren't, a hoax? Or there's been a lot of that stuff going on as we're trying to buy stuff, the supply chains, and how are we trusting that we're actually getting supplies that meet our needs?
Yeah, and I'll echo what Dan just said. We're doing the same thing in Dallas, and so far so good for us. We have done well. But it's an all hands on deck process. We're scrambling. We're going to every supplier we know. There is a vetting process, as Dan referenced, that is very necessary. And we will be looking at ways to stockpile, because there is going to be another surge later, in the fall. So it's an ongoing process, and it is a concern for us. We've done okay.
John, did you have something you wanted to add there?
Yeah, so I can tell you that from the task forces that I'm a part of, that it's been made clear to us that the supply chain is very much behind the 8 ball right now and playing catch up. And the hope is that the catch up will occur during this summer before the second wave hits. And there's a lot of allowances that are being made. And it's actually, from a standards perspective, creating challenges for folks like me. Because, I have standards that say this is what droplet precautions are. And now you have guidance coming out saying that's what droplet precautions are, but you can do this now instead because there's just not enough stuff. And that creates a huge safety concern and challenge. And really the way the supply chain has been running for this has been so disorganized that it's created a lot of challenges for first responder organizations. The other thing is the prioritization has created challenges. People need to understand that EMS and the fire service are part of healthcare. They're part of the healthcare continuum. And when you say healthcare is a priority, not first responders, that's discounting the work that first responders do. So one of the messages that the elected officials, and Bill will definitely confirm this, need to hear is that as important as your healthcare workers are, so are your first responders. When you look at what's going on in the country right now with COVID-19, and you see that EMS, if anything, is part of what's keeping the volume on healthcare, the continuum of healthcare down, by treating people at home, by providing services that they need at their houses, by transporting them to alternate destinations, with no reimbursement structure for it currently. The leadership and the politicians need to understand that that's being done on the backs of EMS across the board and on the fire service. And it's so important that we recognize that. And as we look at making a sustainable financial model for EMS and the fire service, we have to understand that they're a part of that healthcare continuum as much as they are a part of the emergency response world and public safety.
So I want to put a twist in this right now. We have numerous comments on the chat about rural communities, and we know the coronavirus pandemic is now going to the center of the country. And of course, a lot of those rural areas are served by volunteer departments or different services. So for those brains in the meeting, what do you have to say to those communities, especially since someone's raising the issue of those volunteer departments are already really challenged with recruitment and retention? Who'd like to address some of that?
I'll start it, Jen. I think there's 3 points on that. I did see that one, and I made a couple of quick points. The first one is, in rural area where you aren't confronted with major challenges, something like this scares the hell out of you. And it would not be surprising to see people not run toward volunteer fire and EMS agencies to volunteer, but to run away from it. And let's face it, that if they are self-employed individuals, and which many are in rural communities, they're going to worry about themselves first rather than the community, particularly if they have families and they have to figure out how to put bread on the table. I think that's one real issue. There's another factor out there that we saw in my department. And again, I'm in a town of 40,000 residents, 200,000 people a day come there for work and so on. And we have a big combination department. Our first COVID case that our EMS units responded to, unfortunately resulted in a contamination. And even though the person was properly protected and so on, they were still contaminated. As a result of that, we lost 15 total members. We lost 6 career and we lost 9 volunteers. So as a result of that, we had to simply say, if you're going to volunteer or be a member of one of our part-timers from another organization, you have to pick a priority. You're either going to be with that agency or with our agency. As a result of that, we lost more people. So again, in organizations where they rely on members that run with 3 or 4 different volunteer fire departments, they're going to lose those people. So I think that you have a recruitment and retention issue going forward with this. And I think that you have a response issue as well, because the less those rural areas have PPE, the less they have in training, and the less they have in support resources, they will not be actively participating. And they'll go out of business faster. We haven't addressed the money issue, which is the next aspect. If they aren't being reimbursed or they can't fundraise, the volunteer departments are going to be in real bad shape.
So Rob McClintock, does the ET3 pilot, does that include volunteer departments?
It would if the volunteer departments are eligible to do the billing. They would need the MPI with CMS. But as long as they have that, they can submit for the CMS reimbursement pieces for sure, yes.
Great, thank you. I see that we have just 2 minutes left in our time together, so thank you for those of you who are with us. I think what I'd like to do now is encourage you to, for those of you who are in the chat room and are attending the webinar, if there are things that we did not get to talk about today, please contact us at the First Center, which is very easy. You can go to the First Center website or just email first@drexel.edu. And if it is not a question we can answer, we will refer it to one of our illustrious panelists and get back with you. So I'd like to ask the panelists just to hang with me for a moment while we say goodbye. Before you all leave, I would just like to share this last slide. There is a webinar series not hosted by Drexel or Dornsife, by Lexipol, about the cost of firefighter injuries. And this is very important as we think about the impact of injuries and exposures that are happening now and before, during, and after the pandemic. So if that is something that is of interest to you, please join this webinar. And I believe these slides and links are available to you. So on behalf of the First Center and the Dornsife School of Public Health at Drexel University, thank you all for joining us. Thank you for your service. For those of you who are doing it, thank you for your research. For those of you who are supporting the fire service with us, and thanks to these wonderful panelists for being with us today. Your time is also very precious as you are standing up for the fire service in all that you do. So thank you for that as well.